superficial colorectal neoplastic lesion, yes. And then I will show you some videos of ESD, but I could not attach the videos to my presentation for a question of format. So in fact, the video will be apart. So okay, so you recognize these two persons, okay? You agree, huh? Huh? Only 1 year ago. 1 year ago, okay. He's nice, huh? He's a nice guy, huh? Okay. So which polyp should be removed and retrieved? So it is different, huh? Which polyp should be removed and which polyp should be retrieved? So which polyp you should resect, remove, resect, and then you retrieve or not the specimen, or you discard, okay? So these are two different questions, two different issues. So the guideline from ESG is quite clear, but it is not a surprise that we should remove all polyps except diminutive hyperplastic polyp in the rectosigmoid. Do you agree, Montserrat? Yes. Yes. Then we can discard diminutive polyps only if we are expert and if we use virtual or dye-based chromoendoscopy. Diminutive polyp can be adenomatous, of course, but the risk of cancer is very limited. Yes, we can, but only if you are an expert, Montserrat. If you are not an expert, no. No. So take care, because there are some medical legal issues behind. If you don't analyze the polyp, and if 1 or 2 years later the patient has a cancer, it can sue you. Because you miss a cancer. Maybe it's not related to the polyps you discard, but okay, it could tell you, okay, you did not analyze the polyp, okay, you made a fault, okay? So only if you're an expert. So I was a little young like this, but I was a great expert when I was maybe 3 years old, okay? Very serious, like now, huh? Very serious guy. So you need a photo documentation. You need to receive a certification to discard. Certification by your scientific society, by ESG. ESG is now organizing a certification in order, my colleagues, to discard polyps, okay? This is important. And of course, you know this classification. I will, maybe Esterman will, yes, you will explain later. So, no, Sebastian will explain later. So this is a nice classification. I participate to this classification. There are 3 types: type 1, hyperplastic; type 2, adenoma; and type 3, deep submucosal invasive cancer. Okay, so quite clear, but in fact, you should distinguish hyperplastic from adenoma, for example. So what is it, Serrat, Raoul? Huh? No, not Serrat, it's just hyperplastic. And this? Adenoma, because it's more brown. You see the vessels, etc. Here, adenoma. Here, no adenoma. Hyperplastic. Okay, so I don't want to insist because Sebastian will explain the difference in between. Okay. That means usually brown means adenoma. Whitish means more hyperplastic, but you should analyze the vessel, you should analyze the mucosal pattern. So, rejection techniques now, okay? So this is the guideline from ESG. It's a nightmare. I promoted guideline at ESG, okay, as president, okay? You should produce guidelines, 50 guidelines. I was good as a dictator, okay? I was a good dictator. But to produce this is too complex. So that's why I'm laughing. Huh? It's too complex, impossible to use. Huh? Okay. So, but I think I will do it more simple. Okay. So first of all, you have diminutive polyps, less than 5 millimeters, and small polyps, more or less. The recommendation are the same. More or less, they are the same. Okay. I begin. Diminutive polyps. No cold biopsy forceps excision, okay, because of high rate of incomplete resection. No hot biopsy forceps, because of course incomplete resection, risk of adverse events. So only cold snare polypectomy, okay? Do you agree, Raoul? Yes, perfect. He always agrees. He's a perfect guy. You are perfect. Huh? And you should include a clear margin of normal tissue surrounding the polyp. So that's why you need to have a dedicated snare, okay? I use a dedicated cold snare. Now, small polyps. Raoul, your recommendation. Cold snare, huh? Cold snare, same. Okay, so the recommendation is the same for small diminutive, less than 5 mm, or less than 10 mm, small polyp. So, okay, including a clear margin of normal tissue, surrounding the polyp. No more biopsy, and no more hot biopsy. Okay, finish. You agree? Oh, everybody agrees? Everybody, okay, perfect. We go. Now, sessile polyp, 10 to 19 millimeters. So in this case, you should distinguish adenoma from sessile serrated lesions. So the procedures are not, should be not the same, okay? Adenoma, Raoul? Huh? Resection, but yes, resection, but which tool? Huh? EMR. EMR. So hot snare polypectomy, okay? So equivalent to mucosal resection with diathermy. And submucosal injection is interesting to avoid the risk of deep thermal injury, okay? Except if you do underwater, but I will explain underwater later. So, and interesting is to anchor the snare tip, okay? So you anchor the snare tip here, okay? And then the snare becomes more round, and we can better take the tissue, okay? At a distance from the adenoma. So it works well. Anchoring is an excellent tip. And there was a this is a French study, we did a retrospective studies, and you see, even with large lesion, more than 3 centimeters, R0 means clear margin, was 50%, and only 2% perforation. Even on a very large lesion, just using a snare, okay? If you anchor the snare. So I recommend to anchor the snare. Now, we change. This is no more adenoma. This is a sessile serrated lesion, okay? Sessile serrated lesion.
Siempre en lesiones aserradas, aun cuando vaya a usar asa fría, lo elevo, porque hay peligro que quede nomás cerrado en los bordes de resección.
I need to have a, okay, but in this case, you don't need to be R0.
I always use submucosal injection.
No. It's easy. It makes things easier, but it's not necessary. I use cold snare.
But if it's serrated lesion, always injection.
Yes, and piecemeal if necessary, okay? You agree, okay? So mucosal EMR with electrocoagulation for adenoma, piecemeal or not piecemeal, cold snare for serrated lesion, okay? Just, I will be brief, okay, sorry, because just how to recognize a sessile serrated lesion. In fact, these are from Netherlands, what they call the WAPS parameters, so I will illustrate this by some pictures from myself. First, indistinct borders. You see, the borders are very indistinct. This is hyperplastic lesion, and this is sessile serrated lesion. You see, we don't see so well the limits. First parameter. Second parameter, cloud-like, you see, cloud-like. And hyperplastic polyp is more homogeneous, okay? But have a look here, just here. This is a small focus of dysplastic tissue, adenoma. So different, I will come back on this, okay? Then, irregular shape, okay? It can be very large like this, okay? Very surprising, very large. And finally, from my collection, dark spots, but I prefer to say expanding clip opening because of the mucus, okay? This lesion produces a lot of mucus, looks like this. More or less round, oval, okay. So this is a sessile serrated lesion. I'm very proud of this picture because this is the smallest one I have seen myself, just using electronic chromodoscopy. You see, only few glands here. So the problem with a nice classification, type 1 is hyperplastic lesion, type 2 is adenoma, but there is nothing for sessile serrated lesion. There is no classification, no column. So we should invent another column, type 1S. Looks like more hyperplastic tissue, but with distinct parameters. And if you combine NICE and WAPS, in fact, you have quite high rate of prediction, okay? especially if you have high confidence. So we should rely on WASP and nice classification, just to better adapt the treatment, to recognize. Okay. So, for example, this is a sessile lesion, even with a small focus of adenoma and complete resection R0. So in this case, when you have a dysplastic component, you should remove and block, okay? And no more piecemeal, finish. No more piecemeal. Because there is a risk that the patient will recur with maybe a cancer, okay? So for example, this case, you see a large lesion, large hyperplastic lesion, area of dysplasia, or here, R0 is necessary. So in this case, finish. No more piecemeal cold snare, maybe ESD, or large mucosal resection, okay, with R0, okay, clear margin. Now, peduncular polyps, any size, no problem, Laura, no problem. All-snare polypectomy, and of course it is recommended to use adrenaline or to put clips when you have a large polyp more than 2 centimeters with a stalk with more than 1 centimeter. Okay, you agree? But when you have a very large peduncular polyp, such as the case we have seen today, okay? Maybe it was not so large, but when you have a large polyp, you don't see the lumen. You cannot do a retroflexion. You are lost. My recommendation, it's not on this side, is to perform ESD, because then you perfectly determine the margin. I went for large peduncular polyp with a large stalk. I prefer to use ESD because I better control the margin, because when I insert the snare, I don't know where is the snare, okay? You agree, Raoul? No. No, okay, it does, okay, no, you should agree always. No? In English.
ESD in peduncular polyps, I don't agree.
Okay, no, okay. So I recommend, of course, old polypectomy in this case, but ESD for large one. Okay, we disagree. Okay, we disagree. So large non-peduncular polyps, more than 19 millimeter. So difference between adenomas and sessile lesion. So it is different, of course. It is different. And in case of adenoma, okay. This is from ESG. We can perform endoscopic mucosal resection, such as this case, because this was homogeneous, such as your case, homogeneous lateral spreading tumor, okay, homogeneous. Okay, so it was possible to do this. But this, frankly speaking, I stopped to do this. I did this several years ago, okay? Now, finish, ESD, even in the second. But yes, it is nevertheless feasible. You can continue to do this, okay? You can continue to do this. So, new advance. First, piecemeal cold snare, okay? So, as I already explained, so this is a new advance, mostly in the right column for sessile serrated lesion or flat adenomas. Flat adenomas. Piecemeal cold snare is feasible. But frankly speaking, this was the case before. I prefer to don't do it now, okay? And it is not so obvious because large cold snaring is very challenging, okay? In adenoma, in comparison to sessile serrated lesions, you have more risk of submucosal extension and submucosal fibrosis, and snare should be very good, should be optimized. And so that's why I really prefer to do ESD. Now, underwater EMR, perfectly demonstrated by Sebastian. So ESG suggests that underwater EMR can be considered as an alternative to conventional OTMR, okay? The principle is that the lesion is floating away from the muscularis propria. So you perfectly demonstrate this. And there are other advantages. You better see the lesion, natural magnification because of the water. You have a natural separation between the mucosa and the deeper structure of, for example, the muscular layer. In fact, there is a reduction in the polyp size, as you saw, okay, thanks to the lesion, which is floating in the lumen, and you secure a deeper vertical margin. So these are different advantages of underwater. Underwater EMR, in my unit now, is the gold standard. But frankly speaking, If you analyze the literature, 7 meta-analyses, no major difference. Similar efficacy for resection, similar adverse events, but maybe shorter procedure time. So it is not so obvious. Huh? It looks easier, but finally literature is not so convincing. Okay. So Raoul, you do underwater EMR?
I don't use underwater resection.
Yes. Never use?
No.
Oh, okay. So you should learn with Sebastian. No? So over advantage, less expenses related to injection needle and injection solution. Okay. No additional time to prepare injection solution. Okay. Is it clear so far? Is it clear so far? Yes? Okay. Now, the only question, and I still think, speaking about adenoma, is to know if a resection is complete or incomplete. This is the main problem, okay? This is the main question. And you are never sure following EMR. You are never sure. That's why resection margin should be treated by thermal ablation using stair tips of coagulation, such as you did, okay? So this is the rule. And because we had some interesting studies, especially this one from Australia, okay? The risk of recurrence is less when you perform thermal ablation of the margins, okay? So always destroy the margin. And recurrence at the first colonoscopy, in fact, it is only demonstrate, it is, when you look carefully at lesion less than 40 millimeter, or lesion where you were in block, finally, there is no much difference. So that means that, okay, this is the rule, but when you have a small lesion, when you perfectly see the margin, maybe it is not necessary. But we continue to recommend ablation of the margin. Okay, this should be the rule. And there was a prospective trial of 1,000 EMR, okay? And you see meta-analysis and decrease of adenoma recurrence rate with more than 50%. So that's why we recommend to destroy the margin with ablation. And another meta-analysis, you see more than 2,000 patients and decrease of adenoma recurrence. Now, in case of adenoma, why not to do ESD instead of EMR? Because EMR is not perfect. You never know, okay? You are obliged to destroy the margins. ESD, you can be R0 immediately. But ESG is very, very weak. They say only may also be suggested. They don't say you should do it. You should do ESD. They suggest to do it, okay? I'm not happy with this, personally. In my unit, we do 4 to 5 ESD a day. Not myself, I do only few cases, but my young colleagues, they do a lot, okay? And because of course this is ESG, they recommend ESD, they recommend in-block EMR, they recommend a lot of technique when you have a case with suspected superficial invasive carcinoma, but in fact, M-block is not R0. That's why I recommend ESD, okay? This is a weak guideline. So the main advantage of ESD is resection is aiming R0, okay? So you have a margin of normal tissue, and this is not aiming R0, of course, yes. And furthermore, if you have a piecemeal resection, of course, for sure, it is not R0. Huh? By definition, it is not R0. But nevertheless, there are different methods of piecemeal, okay? You have good methods and bad methods, okay? For example, this is a very poor method. So you perform, it's like a puzzle. You take one piece, like piece, and a piece, okay? But they are not coalescents. This is a disaster, okay? You agree or all, huh? Not good. For example, this case, you see, you have a lot of adenoma tissue in between. From a great French expert, huh? No. And finally, he performed APC destruction. No, this is not acceptable, okay? We should perform this. Of course, it is a little challenging, coalescent, okay? And finally, the results are not so bad, huh? A large piecemeal EMR, huh? Results are not so bad. This is piecemeal, huh? Of course, it is not R0, but it looks nice. such as in this case, you see it looks nice. But this is snare. You see the snare. You see the shape of the snare. But it was a large lesion with a large nodule. So it is not an indication for piecemeal EMR, but this is for several years ago, okay? I was happy with this case several years ago, but now, no, finish, ESD. Because the problem is not the risk of recurrence. This is not a problem, because you can do another colonoscopy. The problem is the risk to cut an invasive carcinoma and to destroy an invasive carcinoma. And we need to diagnose this invasive carcinoma before resection. But it is almost impossible. Huh? We have some parameters, but it is almost impossible. So there is a clear balance between ESD, perforation risk, procedure duration, and prediction of histology failure and histology failure. So histology failure, sorry. So, and there is a 13% risk of invasive carcinoma. So clearly, we should not take the risk of carcinomatous evolution. We should take the risk of perforation. Okay? We should take the risk of perforation and the risk of bleeding. We should take the risk of long procedure, and this is much better than the risk of carcinomatous evolution. And which is the rate? And you see the rate of submucosal carcinoma is more or less 20%, okay? Or when the lesion is more than 20 millimeter for Kudo, but in fact, in this series, 13% when the lesion is more than 20 meters. So it is not new, huh? This is quite large. So how to detect submucosal carcinoma in adenoma? This is the problem. There are several classifications, the Paris, the GNet classification, LST classification. I will be brief because probably it will be covered by Sebastian. Of course, you know the Paris classification. Look at the depressed and ulcerated. When you have a depressed lesion, ulcerated lesion, in fact, the risk of submucosal carcinoma is quite high. So in this case, no endoscopy, or if you do endoscopy, ESD, okay? Always ESD. Now, GNet, nice connect classification. In fact, you are obliged to use magnification, and this is the GNet. So it looks more or less like the NICE, okay? Type 1, 2, 3. But you have another column, 2B. 2B, it looks like adenoma, but with irregular pattern of a vascular network, irregular pattern of a mucosa. So in this case, this is 2B. So what to do? In fact, it's clear. 2A, regular pattern, EMR is possible, okay. But when you observe this, no, there is a risk of carcinoma, so you should perform immediately ESD. And of course, this one, amorphous, etc., you don't see very well the vessels, so in this case, surgery. So there is a deep submucosal carcinoma. In fact, the problem is that even in 2020, 41% of procedure have been performed by surgery, and which was unnecessary. So surgery is still promoted too much. If you look at an expert from Japan, the accuracy to distinguish type 3 to type 2B. Type 2B is ESD, type 3 surgery. You see quite good accuracy, perfect in Japan, quite good. But we conduct an evaluation in Europe. Maybe in Europe we are not so good to detect 2B, to separate 2B from 3. In fact, these are our Japanese colleagues, and we conduct this study, okay, with Evelyn Decker from Netherlands. And in fact, there was no difference between Japanese colleagues and European colleagues. The Japanese colleagues, when we work with European colleagues, they are not so good. Are not so good, finally. The truth, they are not so good. And accuracy for type 2 and 3 was not sufficient. Okay. So don't rely so much on GNet. Don't rely so much on analyzing the polyp. Don't rely, okay? LST, of course, it is interesting. But of course, I will not insist. Of course, whether lesion is non-granular, there is a high risk of submucosal carcinoma, high risk. When it is homogeneous, granular, such as the case, your case, the risk is very low. So in this case, you can take the risk of piecemeal. But here, you should perform ESD. So for example, you see homogeneous or mixed nodular, yes, maybe you can perform EMR. But in this case, or this case, flat, pseudo-depressed, ESD. So okay, it's another way to analyze the polyp and to decide for ESD. So for example, clearly indication for ESD in Japan, LST non-granular, especially pseudo-depressed, LST granular with a large granule, or pit pathogenate 2B, but also if you have fibrosis. So this is clear for Japanese. And personally, I think we should not totally rely on all these classifications, okay? These classifications are helpful, but they are not perfect. So LST classification, NICE classification, GNet classification, Paris classification, they are not perfect. So that's why in my unit, we do ESD. We do ESD. And I'm sure in 10 years, everybody will do ESD. And this is a very convincing randomized study from France, which has been published recently, okay? More than 300 patients, we randomized ESD versus EMR, and 8 recurrence with EMR, in comparison 1 with ESD. Of course, a little more adverse event with ESD, but you should take the risk of adverse event to avoid the risk of recurrence and to avoid the risk to treat a carcinomatous component. So, and now just to finish ESD, underwater ESD is also interesting. You have a lesser procedure time, you have a greater dissection speed, but there is no difference finally, nevertheless, in R0 resection, okay? So now we are doing more and more frequently underwater ESD, such as underwater EMR. And this is nice, intermuscular ESD for rectal lesion, T1, SM2, or T2, okay? In this case, you dissect between the 2 layers of the muscular layer, and it has been promoted by Moons from Netherlands too. And we do now, it's a very nice procedure. Not so easy, but it works. With R0, quite good in this case. Now, we spoke about adenoma. Now we come back to cesarcellular lesion. It is the same story than with polyp less than 19 millimeter, piecemeal cold snare if no suspected dysplasia. But if you have a suspected area of dysplasia, you should resect it en bloc, but more important by ESD. En bloc is not bad, huh? You see en bloc, and not on piecemeal cold snare. Even for large lesion, piecemeal cold snare, cesarcellular. You see, the recurrence rate is not so high. With some bleeding, some risk of perforation, but it's quite good, huh? Piecemeal cold snare polypectomy. It's quite good, even for large lesion, for cesarcellular lesion, but not in this case. Not in this case, and not in this case. This case, you see, you still have cesarcellular tissue here, but here you have a large piece of dysplasia. So ESD is necessary in this case. Now, challenging polyps. I don't know how many time I have, maybe more, 20 minutes more. Okay, challenging polyps. I will show you the video. What does mean challenging polyps? Do you all agree with previous slides? Okay? Okay? You all agree? Okay? Of course, I know that you probably perform piecemeal MR. Okay, but now we do ESD. Okay? Except for lateral cesarcellular lesion, we still do piecemeal cold snare, okay? Except when there is a dysplastic area. This is the main message, okay? Now, you can have a challenging polyp, means fibrosis, or you have a scar following mucosal resection, or the lesion is on an appendix or diverticulum. So in this case, it is more challenging to perform resection. So we can use FTRD. So this is more or less like, oh, this is an Ovesco, okay? So we suck with a cap, and in the same time, we place a large clip, and we cut the tissue with a snare. Okay. Who is using FTRD in the room? Yes, not so much, because it's quite expensive. Huh? And I never use. I use Ovesco clip in case of perforation, but I never use this, because it is a little imprecise. You see, morbidity is quite high in case of appendix, lesion located on appendix, 12% of appendicitis. We prefer to use ESD with a traction, traction here. And you see, morbidity is not null too, but R0 is quite good, okay? And I will show you some pictures. So ESG suggests EFTLD to be considered, not to be recommended, just to be considered. Non-lifting lesion without sign of submucosal invasion, lesions invading the appendix or diverticulum, or residual lesion or recurrent lesion. They suggest, they suggest. But I don't like so much because it is impressive. You don't know very well, and you don't have a clear margin. But nevertheless, the R0 lesion is not so bad, okay? A large meta-analysis, R0, okay? It works significantly better if there is a recurrence, okay? But when the lesion is light, of course, more than 20 millimeter, R0 realization rate decline, of course, okay? So that's why I'm not happy with this technique. So I prefer to recommend clip rubber band traction, yes, and ESD. So we did this in France since more or less 8 years now, okay? And we have better R0, better monoblock. We go faster, less perforation, using traction for appendix. I will show you. Maybe I stop, and I will show you some videos. Sorry. First video, appendix, okay? Oh, sorry, I made a mistake. This one, maybe. Well, maybe I made a mistake. Does it work? Yes. So this is, if I stop, okay. You see, this is appendix, and we perform a circumferential incision, and you see in the appendix, you see the adenoma, okay? You see adenoma, okay? Circumferential incision, okay? And then you will see the result, which is quite impressive, So this is the appendix without the mucosa. We remove completely the mucosa from the appendix, okay? Nice looking, with traction, okay? How is it feasible? Is it feasible because we use traction? And we use underwater, and we inject, of course. And I just want to show you this. It's maybe I will try to be short, but this is this is a device which has been invented in my unit. We call it Attract. This is different from a rubber band. It's a more complex rubber band. So this is a large lesion in the cecum, okay? And you see large nodular. So for this reason, it is certainly an indication for ESD because you have large nodular, okay? Not here, but at the top you have large nodular. So it's you see, and sometimes looks a little irregular. So okay, so in this case, it's certainly not an indication for EMR, it's an indication for ESD. So we perform first injection, okay? And then circumferential incision. For this, as you know, we use a water jet dissector. I'm invented on one, I use it frequently. Okay, so we perform circumferential incision, etc., etc. And then you see how nice is the incision because we inject a lot, and following section we use dissection coagulation, soft or not soft, but switch coagulation to enlarge the rim, okay? We enlarge the rim as soon as possible, okay? We enlarge the rim. And then this is a little complex, I must say. So we insert a first clip with a thread, okay? A thread here, you see? The system is a little complex on the left, but you will understand. We take another thread and we will insert, we'll use another clip on the opposite side, yes? of course, we put the clip exactly at the edge of the lesion, okay? Okay? And then we attach the rubber band to the opposite wall, and we continue, okay? We continue. So we better see, thanks to the traction. Traction is mandatory. We better see. And then, you see, when it is attached like this, okay? The problem is that the traction, the traction, in fact, when you continue to dissect, the traction is less effective, okay? The traction is less effective. It's nice, okay, you see, nice, but the traction is less effective. So that's why we have a thread here, and we pull on a thread, and then all the edge of the lesion comes very close. And the traction is more strong, very strong, very strong. It's a little complex, I must say. Huh? But you see, we pull on the thread, we pull on the thread, we pull on the thread. Then all the clips, they come together. And then you will see that we have a very nice lifting. Thanks to this system. We call it attract, okay? It is adaptive traction system. And when we can dissect. Things, okay, even myself, I'm now a very old expert. When I'm using a traction, it's easy. It's easy. You see? You have no problem to see where is the submucosa, and you have no problem to see the muscular layer on the left and the mucosa. Okay. So this system is quite helpful. Rubber band is helpful, but when you can adapt the traction, it's more helpful. Okay. So finally, we finish. Okay. So I will show you another video now. This is a diverticulum. Okay. So this is we are in the sigmoid column, and this is a diverticulum here, invaded by adenoma. Okay. Totally invaded by adenoma. So in this case, it was surgery before, okay, surgery. But now, no more surgery. Finish. Okay, submucosal injection. We begin the circumferential incision. We enlarge the incision using swift coagulation, okay? We place the first clip, okay? So you see the system is a little complex. Sometimes I'm lost when I use the system. I don't know which thread I should take. I should attach with a clip. Then we attach the rubber band, okay, yeah. And so now we better see the submucosal. So we better see the submucosa. We begin the dissection, even in the diverticulum, okay. In the diverticulum, and then we attach two. We have 4 clips. We can attach 4 clips. We have 4 threads. So we attach two more threads, okay? So totally four threads all around the lesion. And following this attachment, we use the last thread, okay, to increase the traction, okay? And now you'll see it's easy, huh? Because you perfectly see the submucosa. You see, lifting is perfect, even in the diverticulum. So, okay, lifting is perfect. And you will see the results. It looks more like an appendix. Huh? So this is the end of the dissection. So we are in the diverticulum. Okay. So this is the diverticulum. Okay, but of course the muscular layer is very thin. Huh? Okay. So that's why we close. But there is only muscular layer. So you can close. There is no mucosa. So we close. Okay. So that's why ESD is interesting. Okay. So this is more or less the end of my talk. Just to finish. So we saw the indications. Okay, the different indications. Okay. Cold snare. Then EMR. Okay, regular EMR for larger lesion. Then piecemeal cold snare for cell-saturated lesion, or maybe mucosectomy underwater versus ESD for larger lesion, larger adenoma. I prefer ESD, okay? We discussed this. We saw the problems related to challenging polyps. Now, just few last sentences. First one is, do we need to close? Do we need to close? It had been demonstrated. I don't want to save time to show the slide, but it has been demonstrated that we should close the mucosal leakage, okay, aperture, in the right column. Not in the left, not in the sigmoid, not in the rectum, okay? First, systematic closure with clip. First point. Now, and to avoid bleeding. And of course, in patients with risk, patient with risk of bleeding because of antiaggregants or anticoagulants, of course. First point. Second point, you should recognize the perforation. When you have a perforation, you should recognize the perforation and you should be ready to close, okay? Okay. So patient should be informed. In case resection is not perfect, in case you suspect a carcinomatous component, okay, maybe the patient needs surgery. Maybe a patient needs surgery. So you should tattoo below the lesions. And India ink is better than clips, okay? Because clips can disappear, okay? Clips can disappear. Antibiotic prophylaxis? No. No. Except in high-risk patients, but no. Usually no, okay. Now, to finish, we should avoid to send this case to surgery. No more surgery for this case. Finish. Except if they do endoscopy. But in France, surgeons, they don't do endoscopy. So not surgery. Finish. Then that's why we need expert centers. And we need to refer the patient to expert centers if you are not an expert in ESD or large EMR. Okay? You agree? And the third and the last advice, you should have an excellent pathologist. Pathology is, an excellent pathological analysis is mandatory, okay? And you should organize a consensus meeting on all cases with a pathologist. So every week, we have a consensus meeting in my unit with a pathologist, with an oncologist, with a surgeon, with, of course, an endoscopist, and we decided about the follow-up of a patient following analysis of a specimen. We analyze the specimen together, and finally, we decide for the follow-up. This is also mandatory, okay? But you need a good pathologist, and at the beginning, my pathologist was not so good. No. I obliged her to train. I bought a micrometer to measure the invasion, and she learned how to cut a specimen, okay? In the past, she destroyed the specimen. So I performed an ESD, and the specimen was destroyed. It was a piecemeal ESD in the end, okay? So I thought, no, you cannot continue like this. You should know how to manage a specimen. So now she knows, and she does perfectly. Okay, this is my last sentence. Thank you very much.